website under live events. So please feel free to download that and you'll have this acronym slide as a reference. For a more complete list, you can find the acronyms list from any page on our website, and that will be linked in the blue bar at the bottom of the page. All right, for our agenda, we will start today by doing a brief recap from Leanne's Part 1 Study Hall webinar yesterday, where she went into more detail on the prolonged care basics, when prolonged care can be billed, and prolonged care billing requirements. Again, if you were unable to attend that session, we encourage you to review the recording from our Encore page or on our YouTube channel once that becomes available. Next, we will do a review of the top denials and rejections for prolonged care. After we review denials and rejections, we do have a question and answer activity planned. And then lastly, after that Q&A activity, we will use any time remaining to take live questions through the chat. And I also wanted to make a note that I have included some resources in our presentation, and I'll actually be going out to show you a few of those. Now, these may be resources that you saw yesterday if you attended Leanne's study hall session, but we really want to make sure you know where these are for today's activity. All right, first we have a brief recap of what Leanne talked about in yesterday's session. Prolonged care codes are add-on codes that must be billed with a primary evaluation and management code. If you just bill the prolonged code, you are going to see denials. Systematically, there would be nothing there for the prolonged code to go along with if you don't bill the E&M service. The prolonged care code would need to be billed on the same claim as the evaluation and management service code. And prolonged care may only be billed when you meet the highest level for your evaluation and management service. Meaning, for example, if you're billing, let's say an established patient office visit, for let's say 35 minutes, and you're billing code 99214, you would not be able to bill prolonged care. And this is because there's a code that is a higher level, code 99215, for established patient office services of at least 40 minutes. So in our scenario, with 99214 for a 35-minute office visit, prolonged care would not be billed. You must exceed the highest level of service time thresholds by at least 15 minutes. So let's go back to that example. The highest level for established patient office visits, code 99215, might be billed for services that are 40 to 54 minutes. So in order to bill prolonged care, that threshold must be exceeded by at least 15 minutes, meaning 54 plus 15. So to bill prolonged care for an established patient office visit, you must have at least 69 minutes. And if that doesn't quite make sense yet, don't worry. We are going to take a look at a few more examples of this when we get to our Q&A activity to help everyone get the hang of it. And I'll also be showing you where those time thresholds are, which will help you in determining when prolonged care may be billed. We had a few pre-submitted questions asking about documentation requirements for prolonged care time. The documentation needs to be an accurate reflection of what the practitioner did for that encounter. It also needs to demonstrate that any prolonged care time billed is accurate. So if you're billing prolonged care for an established patient office visit, but your documentation only shows 45 minutes, well, we just learned in our last example that you must have at least 69 minutes. So in this case, the documentation does not support billing prolonged care. Another pre-submitted question was, please specifically address what documentation should look like. Is time enough? What clearly illustrates prolonged time for Medicare? And the answer for this is that you want to include what activities are included in that prolonged care time. Now, let's say that you bill for prolonged care and the documentation shows 90 minutes, but the only information in the medical record is that the patient has a sinus infection and the provider ordered antibiotics. That documentation is not likely going to support billing for prolonged care and doesn't necessarily match the 90 minutes, especially without providing more information on how that time was spent. So you want to make sure that the documentation shows what activities are included in that prolonged care time. And in yesterday's session, Leanne gave some examples of those activities. Some examples she gave were obtaining or reviewing separately obtained history, such as a conversation with a family member, or independently interpreting test results and communicating those results to the patient as long as it's not separately reported. And again, those are just a few examples, so you'll want to make sure that there's documentation of what actually occurred for that encounter. On this slide, I have included our top prolonged care denials. This is based on data for codes G2212, G0316, G0317, and G0318 for claims that were submitted December 1st, 2024 through May 31st, 2025. And our biggest denial for prolonged care was actually something we've already talked about a little bit, which is must be billed with a primary service. And this could happen if you're billing your prolonged care codes without the primary evaluation and management service, or it could happen if you're not billing it on the same claim. Again, those codes need to come in together on the same claim, otherwise your prolonged care codes will deny. Our next top denial is units of service exceeded, and CMS has established maximum units of service a provider would bill under most circumstances for a beneficiary on a single date of service. And these are called MUEs, or medically unlikely edits. And exceeding these amounts could cause this type of denial for your prolonged care codes. And you can find the MUE amounts on the CMS website. And I'm going to go out of the presentation for just a minute and show you where to find that. So first I've opened the CMS website, which is cms.gov. From the CMS website, you can go right here to the search bar and type in medically unlikely edits. Now, because it's a popular search term, it is pre-populated here for me, but in case it's not, again, you would just search for medically unlikely edits. So from these search results, I'm going to click on this top link, which is Medicare NCCI Medically Unlikely Edits, or MUEs. From here, we're going to scroll down just a little bit, and what we're looking for is under related downloads. You would download the Practitioner Services MUE Tables zip file, which I have already done. Now, once that zip file downloads, you'll open it up and see these Excel and CSV files. And you can open whichever format you prefer. They do contain the same information. My preference is to open the Excel file, which I have already done because it can sometimes take a minute or two to load. All right, so this file shows you those MUE edits that are published. From here, you can do a search, or you can hold down the Control and F key and look for your prolonged care code. I'll look up our prolonged office services code, G2212, and press enter. The MUE value in column B tells us the maximum units of service allowed is 6. And then the next column over, column C, is the MUE adjudication indicator, or MAI. And the MAI for this particular code is 3 for a clinical date of service edit. which tells us that the MUE value of 6 is the maximum units of service you would report on a single date of service. So in this case, if you were billing, let's say, 8 units of G2212, you will receive a denial since the MUE value is 6. And I'm not going to go into any more detail today on MUEs for the sake of time, but did want you to know where this was since it was one of our top denials for prolonged care. For those of you who might be looking for more information on MUE, we do have videos on our YouTube channel specific to medically unlikely edits. All right, let's head back over to our presentation. So next on our denial list is claims denied while the beneficiary is in a period of managed care. And this would happen when the beneficiary is enrolled in a Medicare Advantage plan. So make sure to check eligibility, and you can do this through our secure portal. And if you find that the beneficiary has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. Next is duplicate charges, which might happen if payment was already made for prolonged services for that beneficiary on that date of service. And if you believe your claim denied duplicate in error, you may submit an appeal. Our last denial is for not payable in a facility. This could happen, for example, if you're billing the prolonged care code for office services, G2212, but the patient is in an inpatient facility. So you want to make sure you are using the correct prolonged care codes. If you are providing and billing for a hospital inpatient visit, 99233, you want to make sure that you use the prolonged care code for inpatient visits, which is G0316. If you billed G2212 in addition to your inpatient evaluation and management visit, you would receive a denial because G2212 is only used when billing prolonged care for office or outpatient services. We did receive one pre-submitted question, which was, if we receive a denial, how would we appeal, as this code seems to be based on the provider's clinical judgment? And for this question, I'm not sure which code you're asking about, so it may help if you put more information in the chat. But for your prolonged care codes, the documentation should support the time for the level of service chosen and for any prolonged care time billed. And you would follow the usual appeals process if you receive a denial. And I have included a link, which is on slide 12, with more information on the appeals process. All right, on this slide, we have our top rejections for prolonged care. And first we had invalid or missing modifier. Now your prolonged care codes do not require a modifier, even if the E&M service has a modifier. For example, if your E&M code requires modifier 25, you do not need to add it to your prolonged care code. Your claim might also reject if you add a modifier to your prolonged code that is not applicable for Part B services. For example, surgical modifiers. That could cause your claim to reject. The next rejection we saw was claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice which provide a bit more information. But this could be, for example, missing a diagnosis. So while prolonged care does not require any specific diagnosis, you do still have to have that diagnosis on your claim. So you'll want to double check your claim form and make sure that all required elements are included in order for that claim to process. One pre-submitted question asked how to avoid rejections. And for these, it may be helpful to check the CMS claim form instructions, and that gives you item by item what's required on the 1500 claim form. Omitting one of those elements could cause these rejections. You can find those instructions in the Medicare Claims Processing Manual. That would be in Chapter 26. Our next rejection is for no submitted charges billed. and the claim will not be able to process without including your submitted charges into line 24F on the 1500 claim form or to the electronic equivalent segment. Leaving that field blank or even with $0 will cause your claim to reject, in which case you would just add in your submitted charges and resubmit your claim. All right, next on our list of rejections for prolonged care codes is clinic number missing or not entered accurately. For these, you want to make sure you have included your clinic's NPI and that it is entered correctly. If you omitted the NPI or maybe you keyed it incorrectly, you would just want to make the correction and then resubmit your claim. Last here on our list is claims for those beneficiaries who have Railroad Medicare, and those claims must be submitted to the MAC or the Medicare Administrative Contractor who processes railroad claims, and that would be Palmetto for your Part B railroad claims. You can verify that the beneficiary has Railroad Medicare by checking their Medicare card, and that would indicate Railroad Retirement Board in a red strip across the bottom of the card. And I've included this next slide here as a reference to help kind of summarize what we just talked about for prolonged care denials and rejections. For your rejections, you'll fix the error and resubmit the claim. Remember that for your rejections, the claim was not able to fully process, meaning a claim determination was not yet made and the claim does not have appeal rights. Those must be corrected and resubmitted or submitted to the correct contractor, for example, for those railroad claims. Now for denials, your next step will really depend on the type of denial you receive. Your remittance advice would really be your best source to determine what's next. It may indicate that you need to resubmit your claim, in which case you can correct your error and resubmit. And in some cases, you may need to correct a minor error that caused your claim to deny. For example, we talked about prolonged care codes denying because the MUE value was exceeded. And this might be based solely on a keying error. For example, maybe you intended to bill 2 units of service for G2212, but mistakenly billed 22 units. You may be able to do a clerical error reopening so that the claim can reprocess with that correction in place. And then you may have denials that will require you to appeal if you disagree with the claim determination. And I did include this link on the slide with more information on how to appeal a claim. While this page is not specific to prolonged care, it could certainly be useful for your Medicare appeals, including for your prolonged care denials. All right, next up, we have planned a little activity to test your knowledge. For each slide, we will be launching a poll, and we invite everyone to participate if you can, and don't be afraid to take a guess if you don't know the answer. For each question, we'll give you all a few moments to submit your answer, and then I'll talk about the correct answer. So here we have our first question. Prolonged care may be used when the level of service for your E&M service is chosen by medical decision-making or MDM. True or false? We'll give you a minute to submit your answer. Again, if you're not sure, that's okay. Feel free to make your best guess. Just keeping an eye here on as answers come in. I'll give it just a few more seconds. All right, it looks like everyone's getting that one correct. The correct answer here is false. Prolonged care may not be billed when you have selected your level of service using medical decision-making. Prolonged care for Medicare may only be billed when your level of service is chosen using time. Let's move on to our next one. Our next question is, prolonged care may not be reported with which of the following evaluation and management services? Is it inpatient visits, critical care services, office services, or home visits? I see those answers flying in. It looks like most people are getting this one right too. All right, the correct answer here is critical care services. And this is outlined in a few resources, but I'm going to go out and show you one now, and I'll ask Leanne to put a link in the chat in case you want to follow along. So you could click on that link, or you could even go to the cms.gov website and type E&M services in the search bar, and this guide would probably be your first result. So we're going to open up the E&M services guide. Here we go. Now, there is a lot of great information within this guide, and I know Leanne went out here for a little bit yesterday too. But what I want to focus on today is, of course, the information on prolonged care. And there's a couple ways you can find that. What I like to do, I'll hold down the Control and F key and search for the word prolonged. And of course, you can find any mention of the word prolonged this way. But what I like to do is I'll press Enter or the down arrow until I get to this third one I find. So this brings me to prolonged services listed here in the table of contents. And from here, I can actually click on the words prolonged services, which will take me to the section of this guide that's dedicated to prolonged care. And here we have some great charts and information on types of prolonged care. Now, as far as this question goes, when prolonged care may not be billed to Medicare, and I'm going to scroll down just a little more, please pardon my scrolling, but we're going to go down to page 12. One more page. Here we go. Right here. So on this line I have highlighted in the first bullet, you can see that prolonged care may not be reported for critical care services. And that actually leads me to our next question. All right, the next question is, prolonged care may be reported for emergency department services. True or false? See a couple coming in. Couple not sures, and again, that's okay. All right, I think we've got most of our answers in. So the answer here is false. The E&M services guide that I pulled up for that last question had this answer. We learned on the last slide that prolonged care may not be reported for critical care services. That same line or bullet point within that resource also noted that prolonged care should not be reported for emergency department services. All right, our next question is, in order to bill 1 unit of prolonged care for office services, you must exceed the total time by at least how many minutes? Is it 1 minute, 1 hour, 20 minutes, or 15 minutes? All right, and it looks like all of our answers have come in. The answer to this one is 15 minutes. You must exceed the time threshold of the highest level of service by at least 15 minutes. Keep in mind that those time thresholds are listed as a range as far as prolonged care is concerned. For example, on a new patient office visit, CMS describes the highest level of service as 60 to 74 minutes. So you must exceed 74 minutes by at least 15 minutes to bill prolonged care. And we'll actually look at where that is after our next question. All right, our next question is, all prolonged care codes allow you to provide the additional time on days other than the encounter date. True or false? All right, thank you all for participating. Looks like the answers are slowing down here. All right, the answer to this one is false. Not all prolonged care codes allow for prolonged time to be counted outside of the date of the visit. And there are a couple of places you can find this information. And one is a resource I pulled up earlier, which was the E&M Services Guide. The other is the Claims Processing Manual, Chapter 12. And I've asked Leanne to place a link in the chat, and I'm actually going to pull that up now. And you're welcome to grab that link from the chat and follow along. All right, so here in the Claims Processing Manual, Chapter 12, you could do a couple of things. You could use that same Control F to search like I did in the E&M Services Guide, but I know in this case, we're looking for Section 30.6, which is all about evaluation and management. And for prolonged care, if we scroll down this table of contents just a little bit further, here we go. I'm going to click on section 30.6.15.1 for prolonged services. And what I really like about this section of the manual is the charts for prolonged care. And I think these kind of take the guesswork out of determining how to bill for your prolonged care. So you can see the time thresholds here for each type of prolonged care. And right here, where I'm highlighting these two lines, you see that the time threshold for the new patient office visit, which requires at least 89 minutes to bill prolonged care. Now, notice below this first chart for prolonged office services, or G2212, it says right here that all time, including prolonged time, is on the date of the visit. So that provides the answer to that last poll question. Not all prolonged codes allow you to count additional time on days other than the encounter date. But what we'll find when we're going to scroll down here just a little bit more, here we go. So under prolonged other E&M visits, the next chart gives the time frame during which prolonged care may be counted. Keep in mind, though, that time used to choose your level of service must be on the date of the encounter. But for some prolonged services, as you can see here, the time counted for prolonged care may be counted on other days. For example, you can see here for 99236 for your inpatient or observation, same day admit and discharge. Prolonged time may be counted on the date of the visit up to 3 days after. So if you haven't already opened this manual, I do encourage you to grab the link that Leanne put in the chat to help with a few of our next questions. I know Leanne mentioned this yesterday, but for those who couldn't attend that session, or in case you missed it, Medicare does not follow CPT guidelines for prolonged care. So we really do encourage you to use these charts within the claims processing manual for your Medicare prolonged care. All right, for our next question, and I think all of you are going to get this one right, but I want to make sure you know where these are. I keep this one saved as a favorite. Charts identifying the prolonged time required for each category of evaluation and management services may be found in which resource? Is it the Program Integrity Manual, Chapter 3, Claims Processing Manual, Chapter 12, the WPS website, or Medicare.gov? I'm seeing lots of correct answers. All right, it looks like everyone learned a lot yesterday, so great job to Leanne. All right, so While all of these resources do contain a lot of very useful information, the charts referenced in this question are in the Claims Processing Manual, Chapter 12. Remember, we also took a look at the E&M Services Guide, which has that section on prolonged services. That also includes these same charts. All right, so now we have a few great resources to help determine when we can count prolonged care time. Our next question is, prolonged care time may be counted for nursing facility care on, is it the date of the visit only, date of the visit and 3 days after, 1 day before the visit, the day of the visit and 3 days after, or the day of the visit and the day after? All right, so for this one, if you selected the third option, you were right. Per that chart in the Claims Processing Manual, Chapter 12, prolonged time for your nursing facility E&M services may be counted 1 day before the visit, the day of the visit, and then up to 3 days after. So for our next two questions, these are going to be for new patient office visits. For this question, we have a scenario where a provider is billing for an office visit for a new patient with 73 minutes total on the date of that visit. Which of these would be the appropriate combination for time spent on this visit? Is it 99204 and G2212, 99205 and G2212, or just 1 unit of service for 99205? Or is it 2 units of service for G2212? All right. For this one, if you answered the third option here, 99205 times 1, you got that one right. Per the chart in the Claims Processing Manual, you must have at least 89 minutes before you start billing prolonged care for a new patient office visit. All right, next up, still looking at new patient office visits. So for this question, the provider is billing a new patient office visit with 77 minutes total on the date of that visit. Which of these is the appropriate combination for time spent on this visit? Is it 99204 and G2212, 99205 and G2212, just 99205, or 2 units of service for G2212? All right, it looks like most everyone got this one right. So for this one, again, the answer is 1 unit of 99205. And with this question, what I wanted to demonstrate is how to use that chart in the Claims Processing Manual. I'm going to go back there for just a minute. And pardon my scrolling again. We're going to go back up to this chart here. So 99205 is used for the highest level of new patient office visits with 60 to 74 minutes. You can see here. So you must exceed that threshold by at least 15 minutes before prolonged care can be billed, which would mean at least 89 minutes. So in our scenario with 77 minutes, we do not have enough time to bill prolonged care according to this chart here. All right, for our next question, we have a provider who is billing an initial nursing facility visit with 97 minutes total. Which is the appropriate combination for time spent on this visit? Is it 99306 and G0317, 99306 and G0318, just 99306, or 99310 and 2 units of service for G0317. All right, it looks like most everyone's getting this right. We have a few more answers coming in still. All right, for this one, the first answer is correct. They would bill the initial nursing facility visit, 99306, and 1 unit of service for prolonged care, G0317. You want to make sure that you're billing not only the correct code for your E&M service, but also the appropriate prolonged care code. G0317 may be billed when you have prolonged care time for an initial or subsequent nursing facility visit, and according to our chart, you must have at least 95 minutes total in order to report prolonged care time with your initial nursing facility visits. All right, we've got a couple more questions. The next one is, prolonged care codes always require a modifier, true or false? Awesome. It looks like every single one of you got this one correct. All right, the answer to this one is false. Remember, that was one of our top rejections too for invalid modifier. So even if your E&M code requires a modifier, your prolonged codes do not require a modifier, and adding a modifier could actually cause your claim to reject. All right, here's our finale. For our final question, you may find additional information on billing Medicare for prolonged care in which resources? And you'll select all that apply from these options here, which are the E&M Services Guide, the Claims Processing Manual, Chapter 12, the WPS Prolonged Care article, and the AMA website. I'll give you just another minute or so. All right, I think most of our answers have come in now. So the answer on this one is the first three. So the E&M Services Guide, which we looked at earlier on in this activity to find out when prolonged care should not be billed. The Claims Processing Manual, Chapter 12, where we looked at those charts. And then we also have a prolonged care article on our website, and I have included a link for that on our resource slide. For the last option here, Medicare again does not follow the AMA guidelines on billing prolonged care. While the AMA does have some great resources on their website, you want to make sure to use the other 3 resources here when billing Medicare for prolonged care. All right, before I check in with Leanne for questions, here is our resources slide. We did look at the first 2, of course, which are the E&M Services Guide and the Claims Processing Manual, Chapter 12. And then the last one we've provided here is a link to the prolonged care article on our WPS website. And with that, I will check in with Leanne and see if we have any questions in the chat.
Ashley, I'm looking at the chat and I do not see any questions at this time.
All right. Well, Leanne, I think that means that everybody's learned a lot, and we're going to go through some wrap up now. All right. So in a few minutes, you will receive an email to thank you for attending. And if you don't receive this email, a few things may have happened. First, you may want to check your spam or junk folder and make sure to add messenger@webex.com to your safe sender list so that any future messages will show up. Also, if you joined by phone only, you would not have received this email as there's not a way for us to capture your email systematically from our attendance record. But no need to worry, if you joined by phone, you are able to email us with the phone number that you joined with. And Leanne will be adding that email address to the chat in a few moments, and we do have it listed on this slide. But make sure you don't delete this email. It does contain your certificate of achievement, and it'll look like what you see here on this slide. We'll have your name and contact hours if you need to turn that in for credit towards continuing education units. Now, if you do think of any additional questions, you have 7 days from today to submit those. You'll send those to our education mailbox and make sure they include the title of our webinar today, which is Pop Quiz Prolonged Care Denials, and the subject line so that they will make sure those emails come over to me. Please do keep in mind that I'm not able to access any claims history, so you'll want to contact customer service for any claims related questions. All right, lastly, please take a few minutes to complete the survey. Tell us what you liked, what we can do better, and suggest topics for future education. Your feedback really is invaluable in ensuring that we provide education that's timely and effective. There are different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. The prompt will look like the picture we have shown here with a little yellow triangle, and we include this image so you know that this is safe. It's not malware or anything like that. And lastly, we do make changes based on your survey feedback. So here we've included some changes that we've made recently. Based on survey comments, we added chapters to our YouTube videos so you can easily navigate to specific information in that video. And we've also added training indicators to our education to help registrants better understand if that education is suitable for them. And Leanne, I want to ask one more time if we have any questions in the chat.
We do not.
All right. Well, with that, I think we will wrap up for the day. We appreciate you all taking the time to join us today and for your participation with our activity. On behalf of myself, Leanne, and all of our provider outreach and education team, thank you so much for participating. We look forward to your survey comments, and we hope to have you join us again for future events. You may now disconnect.